Hello and welcome to the Continuing Education Project on post-op pain management, managing expectations through pre-op engagement and education. This presentation is brought to you by Joseph Antone and Jill Shedfield, DNP students here at Nebraska Methodist College. Post-operative pain is not adequately managed in greater than 80% of patients in the United States. There are differences in experiencing pain amongst various populations due to genetic differences as well as social and cultural background. Therefore, pain must be assessed and managed on a patient to patient basis. Surgery ranks right behind degenerative joint disease as one of the most common causes of chronic pain in patients who attend pain clinics. Typically defined as pain persisting for more than 3 months after surgery, chronic pain is recognized as a complication of many common surgical procedures. Chronic pain has a significant impact on the quality of life and daily activities of sufferers. There is also a significant cost to society in terms of subsequent healthcare costs and social support systems. Furthermore, inadequate post-op pain management is associated with increased morbidity, functional and quality of life impairment, delayed recovery time, prolonged duration of opioid use, and higher overall healthcare costs. Poorly controlled acute pain after surgery has been consistently shown to be a predictive factor for the development of chronic pain. More effective anesthetic perioperative measures to help prevent the adverse consequences of poorly controlled pain include the transition to persistent pain. Traditional opioid treatments continue to be a mainstay of post-op pain management, but opioid analgesics use involves the attempt to balance between pain control and harmful side effects. Pain control with conventional opioids can be suboptimal, related to small therapeutic windows and their unselective mechanism of action. Again, the failure to provide good postoperative pain control is multifactorial. It involves insufficient education, fear of complications associated with medications, poor pre-op pain assessment, and inadequate staffing among the main concerns. The goal of post-op pain management is to relieve pain while minimizing side effects. The learning objectives for this continuing education presentation are to identify different educational techniques and learning styles, understand the pathophysiology of pain, identify operations and procedures and what level of pain can be expected, recognize conditions that contribute to ineffective post-op pain control, identify techniques used to communicate pain goals in the pre-op setting, and finally to recognize different classes of medications that can treat post-op pain and other non-pharmacologic interventions. By the end of this presentation, the learner will gain a better understanding of these objectives, obtaining insight to the ideal post-op pain management plan. They will be familiar with the challenges, etiology, risk factors, pathophysiology, educational techniques, how different surgeries affect pain and management, patient-specific pain goal settings, types of pain, as well as both pharmacologic and non-pharmacologic interventions. One of the many challenges to surgery is the risk of chronic post-op pain. Despite the substantially increased attention focused on pain management, acute post-op pain still goes undertreated. The management of pain is one of the challenges for nurses who care for patients during post-op period. Inadequacies in the management of patients with acute post-op pain may be due to many factors. one of which may be negative attitudes and misconceptions among some healthcare professionals with respect to opioid analgesics. Similarly, patients often hold misconceptions related to opioid use that impact the intensity of the pain management they receive. Post-op pain continues to be undermanaged. There are more than 45 million surgical procedures that occur each year in the United States. These procedures vary greatly. However, tissue damage and trauma inherent in these surgical procedures almost invariably results in acute post-op pain, which can range in intensity from mild to very severe. Historically, however, treatment of this pain has been relatively low medical priority due to the lack of sufficient training in pain management. However, many patients have simply accepted the fact that acute post-op pain is to be expected during their hospital stay. The use of education to improve nurses' knowledge of pain and enhance their pain assessment skills and management practices has been shown to minimize post-op pain scores. Preoperative screening may identify patients who are at increased risk of chronic pain and can facilitate targeted pre-op interventions to reduce pain and increase patients' ability to cope with pain. Our literature shows a drastic need for more education to nurses both in the pre, peri, and post-op setting. Surgery is both psychological and physiological. There is multiple stressors on the human body. Therefore, as nurses need extra education, patients too need to be more effectively educated on procedures and the post-op pain they will experience. The Association of Perioperative Registered Nurses underscore the importance of pain management, stating, clinical studies have linked suboptimal quality pain management to prolonged post-operative recovery, diminished patient well-being, and an increase in risk for chronic pain. These assessments should be conducted in the pre-op setting and followed all the way out throughout their hospital stay. Studies have found a connection between less than optimal pain management and prolonged post-op recovery period. This reduces patient outcomes, well-being, and raises the risk for chronic pain and further post-op surgeries. All pain after surgery can and should be managed to optimize physical and emotional function. Nurses should identify in advance those patients who may require special attention. For example, patients who have behavioral issues or patients who are already treated by pre-surgical opioids. Nurses should adopt a multimodal approach that combines several types of medications when feasible, non-pharmacologic interventions to reduce the reliance on one single mode of treatment. Nursing should take into account patient differences in experience and reports of pain. They should take into account preferences among possible treatments and how they respond to therapy, reflecting on risk or factors such as age, gender, and ethnicity. Nursing should discuss with surgery whether the proposed procedure is likely to produce pain, and if so, how intense it is likely to be, for what duration, and how they plan to manage it. Nursing should call to the attention of the surgeon or other team members the relevant aspects of medical history or current status, such as prior pain problems, current pain therapies, and conditions such as adverse reactions to medication. Nursing should continue to assess patient from the pre-op all the way through the discharge process. They should recognize and treat persistent pain and other undesired surgical consequences as early as possible. These plans should be well documented in the discharge summary and communicated with primary care and outpatient management. Poorly controlled post-op pain is a common occurrence. The causes stem from a multitude of factors, but it is important that nursing understand these experiences are highly personalized. Nerve injury and inflammation can promote chronic pain, impair normal functioning, and lead to long-term disability. This leads to long-term chronic use of opioids and other medications for pain relief. Specific surgical interventions can be associated with the increased likelihood of continued post-op pain, which can lead to chronic pain. These techniques will be further discussed in this presentation. The chronic pain rate is 1 in 2.5 after coronary artery bypass, 1 in 5 after a total knee arthroplasty, and 1 in 6 after an inguinal hernia repair. There is some data that suggests that 1 in 10 cesarean section operations lead to chronic pain. It is important that as nurses we understand the differences in surgical procedures and how these procedures might affect the chronic pain or pain experienced by our patients post-op. It is critically important for recognizing patients at risk for post-op pain and identifying potentially modifiable risk factors. As pain is a multifaceted and highly personal experience, various factors are now well-known predictors of post-op pain intensity and analgesic consumption. One of the major risk factors for post-op pain is nerve injury. Many of the operations associated with the development of chronic pain involve major nerves in the surgical field. Intraoperative nerve injury should be minimized to reduce development of chronic pain. Laparoscopic surgery, for example, may reduce the risk of intraoperative nerve damage because of the lack of invasiveness. Many operations, however, do not involve transection of nerve trunks, but nerve injury may still occur due to stretching or crushing of nerves during the retraction or cutting of skin, viscera, fascia, muscles, and joints, all of which are innervated by sensory nerves. Pre-op pain is a major predictor of post-op pain. Pre-op pain can be divided into 3 subcategories: preoperative pain or analgesic experience, patient's perception regarding pain or analgesia, and pain threshold. In terms of preoperative pain, a higher level of preoperative pain, as referred by surgery, has frequently been identified as a risk factor for post-surgical pain across a range of surgery types. On one hand, in physiology, repetitive painful stimulation or sensitization in healthy subjects were reported to decrease pain perception over time and cause habituation. On the other hand, if some use the counter-stimuli for pain relief, i.e. opioids or pain medication, results of habituation remain discussed in the pathophysiology situation. We will discuss pathophysiology later in this presentation. Preoperative analgesic drug consumption is a marker of chronic pain post-op. Opioids work in a hyperalgesia phenomenon, causing opioid tolerance. Chronic pre-op opioid tolerance is a major problem for post-op pain management. It is particularly true if patients had other addictive behaviors, such as smoking, alcohol consumption, recreational drug use, and polysubstance abuse, such as benzodiazepine consumption, or a self-perceived risk of addiction. Psychological factors predict the trajectory of acute and chronic pain or analgesic consumption as well. There are various tests that can be commonly used to study all these factors. This can be completed in a primary care, pre-op, post-op, or pre-discharge from the hospital setting. In terms of age, research suggested it is common to find a negative correlation with both post-op pain and analgesia consumption. This is a negative correlation that suggests the younger the pain, the more post-op pain or analgesia requirement there are for the same surgical procedure. We found multiple research articles that suggest female patients were found to have more post-operative pain than males. Usually, women report clinical pain to be more intense than men, with greater frequency of painful episodes presenting at more body sites. There are many factors that may be contributing to this. There is growing interest in the concept of genetic variability accounting for some of the variability in response to painful stimuli. For example, the abnormality in the voltage gate sodium channel. There is current research that looks at the pharmacokinetics and pharmacodynamics of opioids and how opioids can be modified. In the liver, cytochrome P450 may contribute to the variability of opioid consumption. P-glycoproteins are highly expressed in endothelial cells and can be an efflux transporter which influences opioid transport, particularly through the intestine when opioids are taken orally, and the blood-brain barrier. These aspects of genetic testing and research further our ability to tailor medication regimens, particularly opioid regimens, for optimal drug therapy. Chronic pain develops more often in people who catastrophize. Catastrophizing pain is characterized by magnification of the value of its threat, rumination on pain, and/or feelings of helplessness in the context of pain. Catastrophizing is more marked among patients undergoing musculoskeletal surgery and is a strong predictor of persistent pain in these patients. Catastrophizing was one of the most reported risk factors we found during our literature search. It has been broadly conceived as an exaggerated negative mental set brought to bear during actual or anticipated pain experiences. Catastrophizers were described as individuals who had a tendency to magnify or exaggerate the threat value or seriousness of the pain sensation. Prior to surgery, catastrophizing may magnify pain intensity. Anxiety, while an inconsistent risk factor for development of chronic pain, was shown to have a positive correlation in pain intensity. The link between anxiety and sleep disturbance is an important factor. Research shows simple explanations from surgery or anesthesiology prior to surgery usually is enough to decrease significantly the post-op anxiety and clarify these patient expectations. These conversations further allow patients to set reasonable expectations, a sense of self-efficacy, lack of fear avoidance, and a better overall post-op outlook. Nociception refers to the processing of a noxious stimulus resulting in the perception of pain by the brain. The components of nociception include transduction, transmission, modulation, and perception. Transduction is the conversion of a noxious stimulus, be it mechanical, chemical, or thermal, into electrical energy by a peripheral nociceptor, a free afferent nerve ending. This is the first step in the pain process and can be inhibited by NSAIDs, opioids, and local anesthetics. Transmission describes the propagation through the peripheral nervous system via first-order neurons. Nerve fibers involved include the alpha-delta or fast fibers, responsible for initial sharp pain, the C or slow fibers that causes secondary, dull, throbbing pain, and the alpha beta tactile fibers, which have a lower threshold of stimulation. Transmission can be reduced by local anesthetic and alpha 2 agonists. Modulation occurs when first order neurons synapse with second order neurons in the dorsal horn cells of the spinal cord. Excitatory neuropeptides, including but not limited to glutamate, aspartate, and substance P, can facilitate and amplify the pain signals in the ascending projection neurons. At the same time, endogenous descending analgesic systems serve to dampen the nociception response. Modulation can be influenced by local anesthetics, alpha 2 agonists, opioids, NSAIDs, and tricyclic antidepressants, and the NMDA receptor antagonists. Perception is the cerebral cortical response to nociceptive signals that are projected by the third order neurons to the brain. It can be inhibited by general anesthetics, opioids, and alpha 2 agonists. There are different types of receptors that detect signals from damaged tissue or the threat of damage, and indirectly also respond to chemical release from damaged tissue. Nociceptors are free nerve endings found in skin, muscle, joints, bone, and viscera. The cell bodies of nociceptors are mainly in the dorsal root and trigeminal ganglia. No nociceptor are found inside the CNS. Nociceptors are not uniformly sensitive. They fall into several categories depending on their response to mechanical, thermal, and chemical stimulation, liberated by the damage, tumor, or inflammation response. The different types of receptors include skin, joint, visceral, and silent receptors that all have varying responses. Likewise, transduction relies heavily on neurotransmitters. These can be broken down into two categories: excitatory and inhibitory transmitters. Excitatory transmitters include substance P, glutamate, and CGRP. Inhibitory transmitters include endorphins, 5-HT3, GABA, and NE. As previously stated, transmission describes the propagation through the peripheral nervous system via first-order neurons. There are two types of neurons we will speak about in this presentation: A and C fibers. A and C fibers are the major pain-conducting nerve fiber in the body. They affect the brain in different areas and involve different pain syndromes. Group A neurons are myelinated, have fast transmission, produce sharp and well-localized pain. Group C fibers are unmyelinated, have slow transmission, and produce dull, achy, and poorly localized pain. The time lag is directly attributable to the difference in the conduction speed of these A and C fibers. Their messages do not reach the brain at exactly the same time. Fast pain, which goes away fairly quickly, comes from stimulation and transmission of nerve impulses over the alpha fibers, while slow pain, which persists longer, comes from stimulation and transmission over non-myelinated C fibers. In relative terms, A fibers carry messages at a speed of a messenger on a bicycle, while C fibers carry them at the speed on foot. C fibers are estimated to account for about 70% of all pain. Modulation occurs within the dorsal horn and within the brain. Modulation involves the amplification or dampening of pain signals from the periphery within the central nervous system. This is the prime target for many of the non-pharmacologic and pharmacologic treatments used in management of pain. These signals can be broken down into the peripheral and the central systems. The peripheral signals include bradykinins, prostaglandins, histamines, and these are released in the inflammatory process. Inflammatory mediators sensitize nociceptors, meaning we increase its responsiveness, i.e., decrease the threshold required to activate it. The central signals are within the spinal and supraspinal mechanisms. An understanding of the supraspinal mechanisms underlying the beneficial effects of the spinal cord stimulation will aid in appropriate application in the development of optimal stimulation strategies for modulating pain signaling pathways. Perception of pain takes transduction, transmission, and modulation and combines that with the patient's previous experiences of pain and emotional or psychological aspects of pain sensation. Cognition is the ability to recognize, discriminate, memorize, or judge, and relate a painful experience to another event. Considerable evidence now indicates that alterations in pain perception are a characteristic of how many clinical pain states. Pathophysiology of pain perception primarily examines these pathologic alterations in the pain signaling system, with contributions from leading researchers in the field focusing on functioning of pain processing system under normal and pathologic conditions. The understanding of pain perception is essential for optimal diagnosis and treatment of acute and chronic pain. Current literature suggests that along with pharmacologic and physical modalities to treat pain, psychologic treatments are effective in reducing post-op pain response. Attention accounts for only a fixed number of afferent signals that can reach cortical centers. Modalities used to treat these pathways include biofeedback and hypnosis. Inflammatory mediators released at the site of tissue injury cause a reduction in the threshold of afferent nerve endings, so that a lesser stimulus is required to activate nociceptors, therefore producing hypersensitivity at the site of inflammation. The barrage of afferent input from the injury site causes central neurons to become hyperexcitable, leading to an exaggerated response by these normal sensory inputs. This process has both adaptive and protective benefits. It heightens sensitivity after tissue damage. It assists in healing, discourages contact and movement. It produces tenderness, which reduces further risk of injury. For example, why you limp after spraining your ankle or any ligament. It's caused by activations of immune system by injury or infection, and is characterized by a reduced threshold and an increased responsiveness. Many of these beneficial processes are usually short-lived, activity-dependent, and mediated largely by glutamate and NMDA receptors that resolve with injury resolution. Patients experience spontaneous pain, allodynia, and hyperalgesia at and adjacent to the site of injury. Acute post-op pain is a result of noxious stimulation of skin, subcutaneous tissues, visceral and neural structures. Nociception is a protective process that helps prevent further tissue damage by triggering reflex withdrawal response and modifications of behavior to avoid injury, i.e., the limp previously discussed. The mechanisms that mediate the transition from this acute adaptive post-op pain to chronic maladaptive pain are not fully understood, although nerve injury and ongoing inflammation play important roles. Persistent pain following surgery can have a neuropathic characteristics, and many of the operations associated with persistent chronic pain, such as a thoracotomy, breast surgery, and amputation, involve major nerves in their surgical fields. Major nerve injury accompanies stretching or crushing, as well as transection. However, intraoperative nerve transection does not inevitably result in neuropathic pain, and avoiding nerve transection does not necessarily prevent chronic pain. Pre-op education should be completed at many different points prior to surgery. Primary educators should include primary care physicians, pre-op nurses, and surgeons. Education should be patient-specific and constructed in a way to best convey information. Research shows group settings can reduce anxiety while having increasing knowledge. Patient and family-centered, individually tailored education to patients or responsible caregivers to include information on treatment options for management of post-op pain, as well as documenting the plan and goals for post-op pain management, have also been shown to be successful. Learning styles should be identified prior to education. Education materials should be directed toward individuals' specific learning styles. Learning styles can include visual, auditory, reading or writing, and materials should be tailored to these 4 styles. Materials can include printed information, videos, audio recordings, and opportunities for patients to do teach-back in efforts to illustrate learning. Education should focus on realistic expectations for pain. This should include a personalized pain goal, not only for the use of a fixed pain scale of a rating of 0 to 10, but also to gauge expectations. Health systems, clinics, and providers that emphasize and utilize the achievement of personal pain goals rather than the organizational targets for pain scores have shown to improve patient satisfaction, in part because the use of personal pain goals signifies to the patient that clinicians listen to the patient's concerns and focus on providing personalized quality care rather than meeting arbitrarily generalized pain measurement metrics. Many patients still suffer from moderate to severe post-op pain despite improvements in pain treatments. Identification of the types of surgery that may result in severe post-op pain could lead to better post-op pain management therapies. High levels of pain were observed after several common minor to medium level procedures, mainly because patients received no opioids or low doses thereof. On the other hand, comparatively low pain scores were observed after a number of major abdominal surgeries, often due to sufficient epidural anesthesia. The quality of care after surgeries associated with high pain scores could be improved by better adherence to evidence-based pain treatment recommendations. Several common minor to medium level surgical procedures, including some with laparoscopic approaches, resulted in unexpectedly high levels of post-op pain. To reduce the number of patients suffering from severe pain, patients undergoing so-called minor surgery should be monitored closely, and post-surgical pain treatment needs to comply with existing procedure-specific pain treatment recommendations. The literature has shown that procedures with the highest pain scores, those with numeric pain ratings on a 0 to 10 scale of a median of 6 to 7, are usually orthopedic trauma procedures on the extremities. Patients reported high pain scores after many quote-unquote minor surgical procedures, including appendectomies, cholecystectomies, hemorrhoidectomies, and tonsillectomies, which rank among the 25 procedures with the highest pain intensities. A number of major abdominal surgeries resulted in comparatively low pain scores, often because of the aforementioned sufficient epidural analgesia. Some conditions that have been shown to increase the likelihood and intensity of post-op pain can include a patient who is younger in age, female, a patient who has preoperative pain, a patient who suffers from chronic pain preoperatively, a patient who is already taking an opioid pain reliever for preoperative pain, creating a tolerance to these medications. Personal pain goals help the patient to set realistic goals and could be personalized based on the type of procedure they will be receiving. Pain treatment and goals must be tailored to the needs, desires, and circumstances of the individual patient. Goals often differ for acute and chronic pain, but still focus on prevention, pain relief, and function. Goals for pain management should be specific, measurable, and patient centered. It is both unrealistic and undesirable to cast no pain as a treatment goal. Goals for pain management should be written in the plan of care. It may include the patient expressing adequate pain relief, minimal side effects from analgesic regimens, maintenance or improvement of functional status, and satisfaction with pain management. Goals solely focused on numeric pain ratings can be problematic. A patient's pain rating may be conceptualized as an attempt to construct meaning of the pain experience, influenced by a range of internal and external factors, rather than a task of matching the pain intensity to a scalable number. Data from clinical trials suggest 33 to 50% decrease in pain intensity is meaningful for a patient's perspective and represents a reasonable standard to determine the efficiency and effectiveness of an intervention. Depending on how severe a person's pain is, this percentage change may only be reflected as a 1 to 2 point change on the typical 0 to 10 scale. Awareness of the average post-op pain intensity after various procedures may thus contribute to improved post-op care by facilitating the implementation of procedure-specific pain protocols and personal pain goals. There are a number of different types of diagnostic criteria and types of pain the nurse should recognize. Acute pain starts suddenly and is short-term. Chronic pain lasts for a longer period of time. Breakthrough pain often happens in between regular scheduled painkillers or opioids. Bone pain happens when cancer is affecting a bone. Soft tissue pain happens when organs, muscles, or tissues are damaged or inflamed. Nerve pain happens when a nerve is damaged. Referred pain is when a pain from one part of the body is felt in another part. Phantom pain is when there is pain in a part of a body that has been removed. Total pain includes emotional, social, and spiritual factors that affect a person's pain experience. Pain can and should be assessed as achy, tender, sharp, shooting, hot, burning, nagging, intense, stabbing, tingling, dull, or throbbing. These different adjectives for pain can refer to different types of pain, different areas of the body, and different characteristics that should be monitored by nursing and surgery. There are multiple diagnostic criteria and types of pain the nurse should be aware of. Onset and pattern of pain. When did the pain start? How often does it occur? Has its intensity changed? The location. Where is the pain? Is it local to the incision site, referred, or elsewhere? The quality of pain. What does the pain feel like? Intensity. How severe is the pain? Aggravating and relieving factors. What, if any, makes the pain better or worse? Previous treatments. What types of treatments have been effective or ineffective in the past to relieve this type of pain? Effective. How does the pain affect physical function, emotional stress or distress, and sleep, as well as barriers to pain? What factors might affect accuracy or reliability of pain assessments? For example, cultural or language barriers, cognitive barriers, misconceptions about interventions. Pain intervention plan should be formulated prior to surgery and reassessed throughout the procedure and post-op. Healthcare professionals risk underestimating patients' pain if no assessment is carried out. Not knowing what to expect with surgery can be very stressful. A prepared patient can anticipate what will happen and will help lower stress, improving post-op understanding. In order to decrease anxiety or stress regarding surgery, the nurse should consider the following. Explain each step of the procedure in detail using simple pictures or diagrams when possible. Meet with the person who will be performing the procedure and write down questions and answers to these questions. Tour the room or the procedure area so the patient is familiar with this setting. Ask what you can expect as an outcome to treatment. These steps can be extremely beneficial in reducing overall anxiety and stress about a procedure and helping to further lower barriers in the post-op setting. There are many non-pharmacologic interventions that can be performed post-op to help reduce pain. Imagery, guiding you through imaginary mental images of sights, sounds, tastes, smells, and feelings, can help shift attention away from pain. Similar to imagery is distraction. Distraction is usually used to help children, especially babies. Using colorful, moving objects or singing songs, telling stories, or looking at books or videos can distract patients. Older patients find watching TV or listening to music helpful. Use distractions appropriately and not in place of an explanation of what to expect. Guided imagery is guided through relaxation exercises such as deep breathing or stretching, can be used often to reduce discomfort. Other non-pharmacologic pain management may utilize alternative therapy such as comfort therapy, physical and occupational therapy, psychosocial therapy and counseling, and neurostimulation to better manage and reduce pain. Other modalities include companionship, exercise, heat and cold application, lotions and massage therapy, meditation, music, art or drama therapy, pastoral counseling, pet therapy, positioning. Physical and occupational therapy may involve the following: aquatherapy, desensitization, psychosocial therapy and counseling. Psychosocial therapy counseling may involve the following: an individual counseling or family counseling session to help reduce overall pain and improve goals. Neurostimulation may involve TENS units, acupuncture, or acupressure. Typically, these are performed by licensed and trained professionals. A multimodal approach to pain management, that is using two or more different methods of medications to manage pain, rather than using just opioids alone, was associated with a decrease in opioid use, in opioid prescriptions, and opioid-related complications for post-op pain. Opioids play an important role in the acute phase of post-op pain management. However, too often they are too heavily relied on to shoulder the burden alone of pain relief. Opioids are a powerful pain medication, but have many unwanted side effects. They can cause nausea and vomiting, drowsiness, which can hinder a patient's recovery from surgery. This has prompted more interest in offering patients multimodal therapies to manage pain while also reducing the amount of opioids prescribed. Current research has shown that NSAIDs and COX-2 inhibitors used in multimodal regimens seem to be the most effective modalities with the greatest reduction in opioid prescriptions and complication risks. Additionally, using a peripheral nerve block in multimodal regimen was also found to be effective in reducing complications in opioid prescriptions. We will now go over different modalities for pain intervention following surgery. Opioids are effective pain management tools that have been used during pre, intra, and post op periods. However, opioid use is associated with post op nausea, vomiting, urinary retention, respiratory depression, and hallucinations. For patients who are on chronic opioid therapy prior to surgery, there is evidence-based research to provide adequate analgesia in post-op period requires more pain management. This means ensuring patients receive their maintenance dose of opioid prior to surgery and post-surgery. Utilizing patient-controlled analgesia or PCA pumps is considered to be one of the more effective measures in post-op pain management. This allows patients to control the amount of medications they receive while also limiting the amount of medication that they can have over a specific time period. Anti-inflammatory agents are excellent options for management of post-op pain. Nonsteroidal anti-inflammatories are known to be opioid-sparing in the post-operative setting. NSAIDs aid in decreasing inflammation through inhibition of the COX enzyme system. More specifically, COX-2, which is stimulated by multiple pro-inflammatory cytokinins, including interleukin-1 alpha, interleukin-1 beta, tumor necrosis factor alpha, and liposaccharides. These cytokinins induce COX-2 to produce prostaglandin E2, an inflammatory mediator that leads to the progression of inflammation and pain. Inhibition of COX-2 enzyme is how a majority of NSAIDs help to decrease pain. However, and importantly, one prominent side effect of NSAIDs is the increased risk of bleeding, which should be a concern for any patient undergoing an operation. Risk of bleeding is especially a concern with Toradol when used for greater than 5 days in the elderly at high doses. There is a long-standing controversy regarding the use of NSAIDs in patients undergoing orthopedic procedures such as hip and knee arthroplasties, spinal fusions, etc., because of a concern that the NSAIDs impair bone healing as well. However, a recent review of the research shows NSAIDs including meloxicam, Celebrex, indomethacin, ibuprofen, aspirin yield no robust data that these agents are an absolute contraindication for orthopedic procedures. The full extent of delayed healing or time course of fracture development is not well defined. Other potential risks of NSAIDs include renal toxicity and thromboembolic complications. Again, these risks should be thoroughly gone over with the patient prior to surgery. Local anesthetics, too, have a large role in intra-op and post-op pain management. Local anesthetics offer an advantage of decreased peripheral sensory input. The mechanism of action for local anesthetics is by stabilizing nerve membranes and decreasing the rate of depolarization, therefore decreasing transduction. There are data from orthopedic literature that use single peripheral nerve and plexus blocks for certain procedures. This allows for earlier mobilization and decreased opioid consumption. There is similar literature found for similar procedures in the abdomen and the spine. Peripheral nerve and plexus blocks are carried out using local anesthetics such as ropivacaine and bupivacaine and can be combined with epinephrine. The purpose of epinephrine is to prevent the spreading of local anesthetic agent away from the targeted nerves. This allows for prolonged nerve blockade and prevention of side effects, which can be associated with systemic exposure. Local anesthetics, like opioids, can be administered through multiple routes of administration during the post-op periods. Thoracic epidurals can assist a patient with thoracotomy. These epidurals can contain local anesthetics such as bupivacaine and ropivacaine, alone in combination with opioid agonists such as fentanyl. This method of delivery decreases the total opioid consumption and decreases systemic effects while providing patients with the ability to cough and continue to breathe. Respiratory depression, however, is a primary concern when patients are given an epidural or intrathecal anesthesia and should be carefully monitored. Other potential side effects from local anesthetics include seizures, cardiovascular compromise, including arrhythmias or hypotension in high doses, or with non-epidural systemic local anesthetic exposure. The development of paresthesias, while rare in clinical practice, is another potential side effect. Other adjunct therapies include the use of gabapentin and Lyrica in post-op periods. This is a relatively new technique compared to the use of opioids and NSAIDs, but can be beneficial in some cases. There is promising data on the use of gabapentin and Lyrica post-operatively and preoperatively to decrease post-op pain. Gabapentin and Lyrica bind to the alpha-2 delta calcium channels that are widely distributed in the central nervous system and peripheral nervous system. By reducing the hyperexcitability of the dorsal ganglion root activated by surgery, gabapentin and Lyrica may prevent the development of chronic post-surgical pain. Both procedures in the orthopedic and OB world have data that show that gabapentin given in the immediate pre-op period resulted in a significant decrease in opioid consumption, as well as fewer side effects compared with those that use systemic opioids alone. The doses of gabapentin ranged widely from 300 milligrams to 1200 milligrams as a single dose prior to a procedure. Therefore, the question remains, what is the optimal dose for preemptive pain prevention for these procedures? In addition, there are promising recent reports regarding the use of Lyrica in certain neurologic and neurosurgical procedures. Common side effects of these medications include sedation, visual disturbances, and dizziness. Other adjunct medication options include clonidine and partial agonist opioids. Clonidine, through its central alpha-2 adrenergic agonist mechanism, has been shown to increase analgesia and allow for lower doses of local anesthetic and opioids to be administered. Side effects include hypotension with clonidine and a withdrawal phenomenon compared to that with withdrawals from certain opioids. More than 45 million surgical procedures are performed in the United States annually. Despite improved understanding of pain mechanisms, interpretation of pain signals, and the development of new analgesic techniques, there is an undertreatment of post-op pain. In fact, it is estimated that acute post-op pain will develop into chronic pain in 10 to 15% of individuals. And of those, chronic pain can be severe in up to 10% of these patients. Persistent post-op pain represents a major clinical health problem, affecting nearly 450,000 Americans each year. This leads to medication dependency, change to the mood and affect of the patient, and greatly affect an individual's ability to function in daily life. Today, many hospital health systems are graded based on how well they manage post-op pain. Therefore, effective and timely preemptive pain control not only benefits patients, but it can improve hospital ranking, reduce healthcare expenditures, and increase hospital reimbursement. Patients should be made aware of the risks of chronic post-op pain, particularly where there is high risks due to the type of surgery or known patient risk factors. This will allow patients to make better informed decisions about whether to proceed with surgery and to understand that surgery may alleviate an existing intermittent pain, but be in exchange for a different lifelong pain. Research shows patients at the highest risk for untreated post-op pain include the elderly and those with lower socioeconomic status. Many of these reasons stem from lack of patient understanding regarding acute post-op pain, lack of appropriate patient education regarding the management of post-op pain, and an inability to afford the treatments that post-op pain from pharmacies and other post-op health care providers. Approximately 50% of older patients who have unmanaged post-op pain continue to experience that same pain chronically for at least 1 year following discharge. Some of the more prominent factors for this include inability to assess pain and concerns regarding addiction. A better understanding of natural history and the consequences of chronic post op pain would facilitate effective strategies for the prevention and treatment. Thorough pre op education has shown to greatly improve patient satisfaction and post op pain outcomes. However, these processes should be given ample time for questions and concerns. Nurses should reflect on personal preferences and methods of delivering patient education, but be willing to adapt their personal teaching styles to further benefit the patient. The management of pain is one of the greatest clinical challenges for nurses who care for patients during their postoperative period. It can be even more challenging for patients who must manage their own pain after discharge from a healthcare facility. Research shows that postoperative pain continues to be undermanaged despite decades of education and evidence-based guidelines and research. Ineffective management of postoperative pain can negatively impact multiple patient outcomes. Prolonged pain is a complication of surgery and can become chronic. Improving patient outcomes should be focused on pre-surgical patient education. Learning styles of the patient should be determined in an effort to ensure optimal delivery of information. Patients should be asked to identify personal pain goals, which will assist in creating realistic expectations for postoperative pain. Patient advocacy focused on multimodal regimens must be a priority for surgical patient care planning. This pain regimen includes the use of pain relievers that may or may not be opioid sources. Current literature states that patients who received the preoperative education intervention reported less severe pain during the first 24 hours postoperatively, experienced fewer and less severe pain medication side effects, returned to normal activity sooner, and used more non-pharmacologic pain management methods postoperatively compared with those who did not receive pre-op education. While this information can be daunting to patients both pre and post-op, multimodal regimens including Tylenol, anti-inflammatories, opioids should be discussed at length with each patient. The ability to translate this information to patients both pre and post-op are critical for patient success. Thank you.